Hello, everyone, and welcome to Warrior University. Thank you all so much for joining us. Welcome, 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 welcome. Welcome to the course series, Curative Therapies, or as Dr. Akshay Sharma likes to say, Transformative Therapies. This is going to be a very fun educational class, like this whole entire course is. So, thank you all so much for joining. We are going to be getting started very shortly, but we want to give people a little more time to come in. We are streaming live on Facebook. We are also streaming live on YouTube, and we are on Zoom. So thank you all so much for joining us. For those that are joining us via YouTube or Facebook, please make sure you put your questions inside of the chat. If you are joining us for the Zoom, and you are very welcome to join us through Zoom, just go click the link that is about to be typed into the chat. Click the link and you can join us in Zoom and ask your questions live. Please put inside, please, if you're joining us from Zoom, please remember to self-mute, and that if you have any questions whatsoever, please just post it in the chat and we'll just ask them right then and there. We are also going to be taking questions at the beginning of the session once it's started, from any questions that was anyone had burning that they thought about over the past week. We're going to be taking some of those questions if you guys have any questions. But please make sure if you have any questions, any comments, to put them in the chat. And thank you guys so much for joining us and always being here and wanting to learn with us. I hope you guys are enjoying Warrior University. I hope you guys are enjoying this course. We still have about a few more classes to go for this course. And remember, once this course is completed, 6 weeks after, we will be posting them on a Warrior Network. And if you have not joined the Warrior Network, this is a plug, please go and join the Warrior Network. We have tons and tons of educations and videos on a lot of different things. So please go ahead, check it out, and it's free. So make sure you go sign up and join the Warrior Network. You're able to watch past classes that we have. Some classes are for partners only, so you won't be able to access those classes, but we have tons of information on different things, on art, on music, on education, on Sickle Cell 101. So please join Warrior Network. Thank you all so much for joining. We are going to be getting started in 1 minute. Thank you guys so much for joining. You guys are awesome. Hi, everyone out there in Facebook land. Hi, everyone out there on YouTube land. And hi, everyone in Zoom. Thank you all so much for joining. I am Dominique Goodson, the Dean of Warrior University, and I am so thankful for everyone that continues to support Warrior University. Also, make sure you keep a lookout. We have a bunch of classes and courses coming up the rest of this year. We have classes scheduled all the way up into December. December, we're taking a little break. But we'll be back next year. And if you have a course that you would like to see or classes that you would like to see, please email me at warrioruniv sicklecellconsortium.org, and I can make sure that we get those classes for you guys. I will put that inside the chat so you guys have that email address. So if you want to see any type of classes happen for Warrior University, please make sure you put that inside the chat and I'll make that happen. So it is now 7:05, and to make sure that we have plenty of time for this amazing presentation, we are going to get started. So thank you all. Hello, everyone. I am Dominique Goodson. If you're just now joining us, I am Dean of Warrior University. First, thank you so much for joining us. Welcome Facebook, YouTube, and our participants in Zoom. Thank you all so much for joining us. Now, just a few rules. If you're joining us in Zoom, please make sure that you self-mute. For everyone, if you have any questions, comments, please put them inside of the chat. We are able to see them on all of the platforms that we are streaming for. So if you have a question that you would like to ask, please place it inside the chat, and I will make sure once I see the question to ask Dr. Akshay Sharma right away, so you get your answer. If you want to wait till at the end to ask your questions, to get your answers for your questions, just remember, please put it in the chat and we'll make sure we get to all of the questions. Now, before we begin, the patients caregivers, and community based organizations of the Sickle Cell Consortium are delighted to provide Warrior University as an online curriculum based education module. However, please note this is a general discussion and is not meant to replace the advice or instructions of your doctor or other healthcare professionals. Statements made are not meant to reflect the policies, thoughts, or opinions of the consortium and do not imply endorsement or recruitment for any product, service, or clinical trial. As a reminder, this class is recorded and will be made publicly available online. Private questions should be addressed to me, Dominique Goodson, or you could directly address them to everyone and we will get them answered. So, without further ado, I would like to introduce our amazing presenter, Dr. Akshay Sharma, as he presents um, on curative therapies. Dr. Sharma,
Hi, how are you?
I'm doing good. Thank you so much once again for doing this. So, I do want to just make one announcement before you begin. Actually, two. I do want everyone to know this class is going to be done a little bit different this time to make it more interactive. Please post your questions inside the chat as they come to. So as Dr. Akshay is talking, as I see questions pop up, I will interrupt Dr. Akshay. He prefers it that way to interrupt him to ask your questions then. So you guys could get your questions answered in live time. So put your questions in the chat as they come to, and I will make sure that they get answered. Also, Dr. Akshay is going to do a brief overview of the class that we had last week for anyone that missed the class last week or have a question that they want to ask. He's going to do a brief overview before he starts the next presentation for the next class. Correct, Dr. Akshay?
Yeah, that's
All
right.
right, great. So, without further ado, take it away, Dr. Akshay.
Thank you. And thank you, Dominique, for inviting me again. So, before I get started about gene therapy, as Dominique mentioned, last week we talked about different kinds of bone marrow transplantation. So, if you all attended that class or have any questions about bone marrow transplantation, please feel free to put them in the chat right now. We can talk a little bit about that first. I'll start talking and you can start typing your questions if you have any. And then we will switch gears and we'll start talking about different types of gene therapy. And as you know, today we are discussing the viral vector based gene therapy. We will discuss all the gene editing approaches next week. So before I start talking about gene therapy, just a little recap on bone marrow transplantation. So bone marrow transplantation basically is when we take blood forming cells from one person and put them in another person. So in this case, the recipient, the person who's receiving the transplant, is usually the person who has sickle cell disease because they are making sickle cells. And those sickle cells are made in the bone marrow. And the cells that make all sorts of blood cells are called stem cells. So, what we do in a bone marrow transplant, also known as a stem cell transplant, we find a donor who's genetically as similar to the person with sickle cell disease as possible. We collect stem cells from the donor. We give the recipient chemotherapy or radiation to kill all the sickle causing, sickle producing stem cells. And then we infuse stem cells from the donor into the recipient. And as these cells grow, they start making normal blood cells in the individual, and the person doesn't have sickle cell disease anymore. So, this is in brief what bone marrow transplantation looks like. And now we are going to take a deeper dive into gene therapy, which is similar but different. So I don't see any questions come up in the chat. So I'm going to start sharing my screen and start talking about gene therapy. All right. All right. I'm sharing my screen. Can somebody confirm that they can see it?
Not yet. It hasn't popped up yet.
All right. How about
Okay,
now?
it is popping up. Yep, we can see
Okay,
it.
perfect. Okay, so as Dominique mentioned, I am Akshay Sharma. I am a physician at St. Jude Children's Research Hospital in Memphis, Tennessee. And today we will be talking about viral vector based gene therapy for sickle cell disease. But before we get started, I do have some conflicts of interest and other disclosures that I want to talk about. So I am a consultant for a number of other companies which are developing different types of gene therapy for sickle cell disease, and I've received some research funding from CRISPR Therapeutics, which was previously, well, actually, it's partnering with Vertex Pharmaceuticals to develop gene therapy as well. And I am a clinical trial site PI for several of these trials at St. Jude. I will not be specifically talking about gene editing today, but I just wanted you to be aware that I have worked with many of these industry partners previously. Um, and then most of the information that I'm giving in this talk is for general education only. I am here as an advocate for patients with sickle cell disease. I'm here to educate all of you. I want you to be able to make informed decisions for yourself. And one of the ways in which you make informed decision is to be informed about it. So I'm here to provide that general education. I'm not providing any specific medical advice. If you have specific questions about your condition, I would encourage you to go and talk to your doctor because they know you the best and they can provide you the best advice. But I'll be happy to answer any general questions today. So today, our objective would be to discuss viral vector-based gene therapy, and I'll describe what that means in a little bit. And mostly, we will be focusing on the Lentiglobin clinical trial being conducted by a company called Bluebird Bio, because that's the predominant viral vector-based gene therapy which is going on in this country right now. We will be discussing different mechanisms of how viral vector gene therapy works, as well as we will talk about some of the published results from this clinical trial. So, last week we discussed in detail what bone marrow transplant looks like, a BMT. And I just did a brief recap of bone marrow transplantation. Bone marrow transplantation, it's a great treatment. It's been around since 1983. We have known a lot. We've learned a lot about bone marrow transplantation, how to do it, what the complications are, etc. But there are still some problems with transplantation. Now, as I mentioned previously, first of all, you need a donor to do bone marrow transplantation, and not everybody has a donor. So, the best donor is a brother or sister who does not have sickle cell disease and who's a full match. But not everybody has a lot of brothers and sisters, and not everybody has brothers and sisters who are a full match to them. So, if you have, four brothers or sisters, chances are that only one of them will be a match, 25%. And that person cannot have sickle cell disease. If they have sickle cell trait, that's okay, but they can't have sickle cell disease. So one of the big problems with bone marrow transplantation is that not everybody has a donor. Now, let's say you find a donor and you do the transplant. Bone marrow transplant comes with some immunological complications. Number one being that when you put somebody else's cells in a patient's body, these cells can attack the person. They can attack the body of the person. This is called graft versus host disease. Now, we do give medications to prevent this from happening, but despite these medications, sometimes some people do develop graft versus host disease. And, graft versus host disease can be very mild to begin with. It can be just a little bit of a skin rash or a little bit of diarrhea. But graft versus host disease can get very, very dangerous. And I have seen some people develop ulcers all over their skin completely sloughs off. They have so much diarrhea that they just sit on the commode all day. And it can be life threatening and can cause death in some individuals. So, graft versus host disease is not something to be taken lightly. Another immunological complication is graft rejection, where the recipient's body attacks the cells and rejects the cells, get rid of them. If that happens, sickle cell disease can come back, and that can be a problem because you've already gotten a lot of chemotherapy and now your sickle cell disease is back. So you did all that for nothing. So these are some big immunological complications associated with transplantation. Now, I mentioned earlier that to do the transplant, we have to give chemotherapy. And I'm sure, as you know, patients who get chemotherapy, they lose their hair. Now, this is temporary. The hair grow back after some time, but this is very distressing to some people, not having any hair for several weeks to several months. Another issue is exposure to chemotherapy can cause infertility. It can affect the gonads, the ovaries, and the testes. And some individuals who have received chemotherapy may not be able to have children the normal way. There are ways around that. We can now do fertility preservation before somebody undergoes transplantation or gene therapy, but it still comes with its own risks. And then, of course, during the process of transplant, as we are giving medicines to suppress the immune system, um, patients are at a very high risk of catching an infection. And these infections sometimes can get very dangerous and can even get life threatening. So, again, that risk remains. And last but not the least, very few, some individuals, about 1 to 2%, so 1 or 2 out of every 100 individuals who undergo transplantation can sometimes develop cancers because of the chemotherapy that they've received. And these cancers can occur up to 10 to 20 years after they've undergone transplantation. So there remains a low, small risk of developing cancer from the chemotherapy that you've received. And lastly, like I've mentioned already, with many of these complications, people undergoing transplantation can even die from the process of transplantation because of the complications of transplantation. So, even though transplantation, we've known for a long time that it is a curative therapy, it can provide an opportunity for a one time cure. It is and remains one of the strongest and one of the harshest treatments for sickle cell disease. Now, these problems, which occur with bone marrow transplantation, the first three of them, that people don't have a donor, that they can have graft versus host disease or graft rejection, we can address those problems if we use a person's own cells. So imagine you don't need a donor, you can be your own donor. So if we use your own cells to do gene therapy, you don't have to worry about finding a donor. And now in gene therapy, as you're getting your own cells back, there is no risk of graft versus host disease, and there is no risk of graft rejection. So I'm going to describe some of these things in the next few slides. But these first three problems that we see because during transplantation, you don't see these problems with gene therapy. Having said that, these last few problems, they are related to the use of chemotherapy. And as of today, all gene therapy protocols require the use of busulfan, require the use of chemotherapy. So these bottom five problems that I talked about, hair loss, infertility, risk of infection, cancer, or death, those still remain with gene therapy also. But the first three problems we can fix. Okay. So there are different types of gene therapy, and today I will talk about the first one over here: gene addition or replacement. The other types of gene therapy, um, there are different techniques to increase fetal hemoglobin that I've described over here, and then lastly there is the precise correction of the sickle mutation. We are not going to talk about those today. We will talk about those in the next class next week. So if you're interested in learning more about that, please join me here next week at the same time, and then we'll discuss those in detail. But today's class will focus on gene addition or gene replacement using viral vectors. Okay, so this is again going to be a very brief recap of what we talked about last week. For some of you who didn't attend the class last week, I didn't want you to miss out on some of the terminology that we are using today. So I wanted to just recap that briefly for you. And for some of you who attended the class last week, this is going to be a recap. So, as I mentioned last week, our body is made up of millions and millions of cells, and these cells contain chromosomes. So if you had to compare a cell, let's say, looks like a book, and these chromosomes are like chapters within that book, and these different chapters are written in sentences, and those sentences are the different genes. So in each cell, there are multiple book chapters, multiple chromosomes, which have multiple sentences, which are instructions for that cell. And these sentences are the genes which tell the cell to do something. What is that cell supposed to do? So, for example, a red blood cell contains genes which tell the red blood cell to make hemoglobin. So here in this diagram, if let's say this is the cell, this is a red blood cell, and it has chromosome number 11, which has HBB gene. Now, sometimes these genes can have spelling mutations, just like you can have a spelling mutation in a sentence in a book. These genes can also have mistakes. So, this spelling mistake in HBB gene is what causes sickle cell disease. So, here I'm showing this is chromosome number 11 over here, and here you have HBB gene, and normally this HBB gene should have a GAG. That's the correct spelling over here. But when you have sickle cell disease, there is a spelling mistake, and the spelling is GTG. Now, what happens is normally these normal hemoglobin molecules, they look like this. They are separate from each other. They carry oxygen inside a red blood cell. But when you have sickle cell disease, and these red blood cells, they are in a deoxygenated environment, low oxygen, they form long chains like this. So these molecules, which are supposed to remain independent like that, they join together, form long chains, and these long chains cause the red blood cell to become C-shaped or sickle shaped, and this is what gives rise to sickle cell disease.
So,
Now,
Dr. Akshay,
yes,
do have a question. So
yes,
the
go ahead.
question is, and it's referring back to that slide. So if it's a spelling mistake for sickle cell disease, is it the same of a spelling mistake for sickle cell trait?
Correct. Yes, that's a great question. So in each one of our cells, we have two copies of chromosome number 11. So you get one from your mom, one from your dad. So we have two copies. And if the spelling is wrong on only one of the copy, then you get sickle cell trait. If the spelling is wrong on both the copies, you get sickle cell disease. So, for example, let's say your dad has sickle cell disease, but your mom does not. Now, the copy that you're going to get from your dad will carry the spelling mistake, but the copy that you carry from your mom will not have the sickle cell, the spelling mistake. So then you have one normal copy and one copy with a spelling mistake. That person will have sickle cell trait. Now, let's say both the parents have sickle cell trait. There is a 1 in 4 chance that you will end up getting both the copies with the spelling mistake. So, if both your parents have sickle cell trait, there is a 25% chance that you will end up getting the spelling mistake copy from your dad and from your mom. And if that happens, then you get sickle cell disease. Is that does that answer your question?
Yes. Another one, and this one's for me. If what would the spelling mistake look like on for sickle cell trait? You know, when you go to the next slide, you tell us that is GTG for sickle cell disease, or like what would it look like for sickle cell trait?
It's the exact same spelling mistake. So this GTG I'm showing here just one time, but basically there are two chromosomes. So if GTG is on one chromosome only, then you have sickle cell trait. If GTG is the spelling on both the chromosomes, then you have sickle cell disease.
Okay, thank you.
Okay, thank you. This was a great question. Thank you for asking. Okay. So I told you that we can use lentiviral vectors to deliver a normal copy of the beta globin gene. Now, how does that happen? So imagine this lentiviral vector. It's like a Trojan horse. It's like an envelope. You can package whatever you want to package in this lentiviral vector. So in this case, I let's say I am a scientist and I know how to make a normal beta globin gene, a normal hemoglobin gene. I can package that normal gene inside this virus. Now, the good thing about this virus is that this virus can enter blood forming cells. This virus can easily enter inside stem cells. So, first, I package the gene inside this virus, and then I cause this virus to go inside the stem cell where the virus releases the gene, and this gene now becomes a part of the stem cell. So, think of it this way: if you wanted to send a letter somewhere, and let's say that letter had the correct spelling of the hemoglobin gene, the beta globin gene, right? You would write that spelling on that letter, you would put it in that envelope. Now, the envelope in this case is a lentiviral vector. Now, you would send that envelope inside the cell, and inside the cell, the envelope will release the letter, it will have the correct spelling, and now it will teach the cell to make a normal copy of the beta globin gene. It's that simple. That's what lentiviral vectors are all about.
So we have a question. What you say is a lentiviral vector, a virus. What virus are they using as the envelope?
Yes, that's a great question. And I was going to tell that right now. So you stole the answer directly from my mouth. So lentiviral vectors are modified HIV viruses. And don't panic. This is an important concept. These are empty HIV viruses. And the reason we use these HIV viruses is because HIV virus is very good at entering inside the cell. But the good thing is, all the genes which cause HIV, which cause AIDS, they have been removed from the virus. So this virus is like an empty envelope only, which only has the outer covering of HIV, but inside everything is what we put in there. We put in the normal beta globin gene. It is not the HIV virus which causes HIV AIDS. It does not cause HIV. It is a modified HIV virus, which only on the outside looks like HIV. And that's important to know because when we use lentiviral based gene therapy, there are different kinds of gene therapy, but when we use a lentiviral vector, um, if somebody were to test that patient who has gotten a lentiviral vector gene therapy using one of the tests that they use for HIV, that person will test positive for that test. But that's not correct. That's a false positive test. It's an incorrect positive test. If that happens, there is a different kind of test called a nucleic acid test, which tests for the DNA. That test, if you do it, it will be negative, which will tell you that the person does not have HIV, does not have AIDS. But more common test that's done, it will test positive, but it's a false positive. Does that answer your question?
Yes.
Okay, so lentiviral vectors are modified HIV viruses, but they do not cause HIV. They do cause a positive test by one of the methods, which is called a false positive test, and then you do the confirmatory test using a DNA-based test, and that test comes back negative, telling the person does not have HIV. Okay.
Another question. Is there another type of virus that they use besides HIV virus as a lentiviral vector? Or is it
No.
just the HIV?
Um, so lentiviral word is for modified HIV viruses. Now there are a number of other different viruses that have been used in the past, which are not modified HIV viruses. But to my knowledge, I don't think any of them are being used for sickle cell gene therapy currently. There was a different kind of virus being used by a company called Graphite Bio to do a particular type of gene therapy. It's called a AAV, if I'm remembering correctly, but that trial has been shut down, and it's not going on anymore. So to my knowledge, lentiviral vectors are the only type of viruses that are being used for sickle cell gene therapy currently.
Okay. And just to make sure it's clear understanding, we are not curing one condition and giving another condition. So we're
No.
not curing sickle cell and giving HIV. Because I remember a few years ago when this was first discussed on CNN, it wasn't explained correctly. And a lot of warriors were extremely worried because it was no type of explanation of what it was. But what you had just said, explained now is very understanding. So I just want to make sure that's clear for everyone.
Yeah, absolutely. This is very important concept because it's easy to misunderstand, and it's easy and confusing for people when they're trying to explain it. So the HIV virus, what we are using is just the envelope, the outside of the virus, because that outside of the virus is very effective in getting inside the cells, but it does not cause HIV at all. Absolutely not. Okay, so let's move on. This is good, but this is complicated even for me. I am a very simple guy, and as I said earlier, I like to make analogies. So I'm going to make another analogy over here. So there is this sentence over here. And I told you there are mutations. Sickle cell disease mutation is like a spelling mistake. So, Dominique, can you tell me what spelling mistake is there?
Yes. You got a capital I, or is that an L? It looks like a capital I. No, it's an L. It's an L. So you got an L instead of an I, where
Okay.
going should be. So it says, I love blonde to Disney Whirler. You got an E where O should be.
Absolutely. So we have two spelling mistakes over here. So what lentiviral vectors do is they actually don't fix the mistake. They just put the correct spelling of the word somewhere in the genes. Does that make sense?
Mm-hmm.
So let's go back. If this is what sickle cell disease looks like, if there is a spelling mistake over here, and we find the spelling mistake, a lentiviral vector isn't going to fix it. It is just going to put the normal words with the normal spelling somewhere in the cell. So you still have the spelling mistake in your genes, but you also now have a normal spelling in the genes. So, what does that mean? What that means is people who get lentiviral vector gene therapy, they continue to make sickle hemoglobin, but along with that, they make normal hemoglobin also because now they have the normal spelling also there. Okay.
So
So
it wouldn't matter. So going back to this, the way you're saying, it wouldn't matter for the genes um, if the sentence is grammatically correct, as long as the spelling is correct.
correct. So I'm going to show you the results of the clinical trial in a few slides and it will make more sense. But what I'm trying to say over here is that if you have the sickled gene as well as the normal gene both there, these cells will have both types of hemoglobin, half of which will be sickle hemoglobin, half of which will be normal hemoglobin. Now, the good thing about that is if you have half sickle, half normal hemoglobin, you become like somebody who has sickle trait. And as we know, individuals with sickle trait do not have any problems. So, this is what lentiviral gene therapy does. It basically makes the sickle hemoglobin half, and rest of the half is now normal hemoglobin. So, these individuals don't have sickle cell disease anymore. They look like sickle cell trait. Okay, so this is a more scientific diagram of what I just told you. So here is the cell, the red blood cell, stem cell, and here in red is shown the sickle mutation. And so we use a lentiviral vector to take the correct hemoglobin spelling here shown in blue. We add those two together, and now the stem cell here in step two has the mutation, which is shown in red but also has the normal globin copy. And when these stem cells make normal blood cells, you see increased amount of healthy red blood cells and decreased amount of sickle red blood cells, and the person looks like somebody who has sickle cell trait. Okay, so how do we do this type of gene therapy? Well, as I showed you last week, this is a patient with sickle cell disease, and on the right side, this is what their blood looks like. As you can see, they have a number of sickle cells here. Now, you don't have to find a donor because I said every person can be their own donor. So the very first thing that you do is you collect stem cells from this person with sickle cell disease. There are many different ways to collect stem cells, but the way that we use now to collect stem cells, it looks very similar to an exchange transfusion where you are connected to a machine. You get an injection of a medicine called plerixafor under your skin. That medicine causes stem cells to come out of your bones where they live into the blood circulation. And this machine, it takes out a little bit of blood from your body, spins it down, collects the stem cells, and then returns the rest of the blood back to you. So this process goes on for about 6 to 8 hours. Sometimes we have to do it 2 or 3 days in a row, and then we can collect stem cells. Once we have collected enough stem cells, we send these stem cells to the laboratory where they use these lentiviral vectors. They add the lentiviral vector into the stem cells. The vector delivers the new gene inside the stem cell. Then we freeze the stem cells. In the meantime, the patient gets chemotherapy, here in this case, busulfan. Busulfan causes these stem cells to die and the bone marrow becomes empty. And then once the bone marrow is empty, we take these stem cells that we have just genetically modified with the lentiviral vector and we put them into the patient as an IV infusion. And as these stem cells grow, they start making normal blood cells. And now this patient does not have sickle cell disease anymore.
So
So
we
I'm
have
gonna,
a question.
yeah,
So someone said when doing gene therapy, is it like a bone marrow transplant but with your own genes,
it's a bone marrow transplant, but with your own cells.
with your own cells? Okay.
Yeah, because the gene we are putting from outside from the lentiviral vector. So you're absolutely right. Gene therapy looks very much like a bone marrow transplantation. You still have to get chemotherapy. You still have to get cells. That is why I said earlier in one of the earlier slides that the only complications that gene therapy helps us address is that you don't have to find a donor. And after gene therapy, you can't get graft versus host disease and you can't get graft rejection because you're getting your own cells back. But the rest of it looks like a transplant. Yeah. Okay, so now we are going to talk about this clinical trial. So the largest study, which has used a lentiviral vector, it was conducted by a company called Bluebird Bio, and this study was called HGB-206 Lentiglobin study. Now there are a number of different names of this, but I think most people still call it Bluebird Bio. Now, on this study, earlier last year in December, they shared the results, the most updated results. And so 35 patients with sickle cell disease had been treated in Group C. This study went through multiple different versions. There was a Group A patients, which were the very first patients that they treated, and some patients did very well, but others did not. So they modified the process. Then they treated two other patients on Group B. They did a little bit better, but then Bluebird Bio figured out how to make it even better. And then they treated 35 patients with sickle cell disease on Group C. And so these 35 patients, they've been followed for a period of from 4 months to 38 months. So a little over 3 years. And when they looked at them, almost all the red blood cells had this hemoglobin A T87Q 6 months after therapy. This A T87Q, that's the hemoglobin gene that they put into the stem cells so that they could differentiate the sickle hemoglobin from the hemoglobin that they were putting. And almost every cell had some expression of this modified hemoglobin that they put in. And what did that lead to? That led to a 99.5% reduction in the incidence of VOCs or ACS. So vaso-occlusive crisis and acute chest syndrome, it went down by 99.5%. So on the right side, I'm showing a graph of this study. And at the bottom, you can see the different months. So at baseline, 3 months, 6 months, 9, 12, 15, 18, 36. On this side, you can see what was their total hemoglobin. So the higher the bar, the more hemoglobin they had. So you can see at baseline, most of these people had around 8 grams per deciliter of hemoglobin. So 8 grams is pretty low. And then after gene therapy, the hemoglobin went up and became 11 to 13 grams per deciliter. And of this hemoglobin, about half of it was sickle hemoglobin, shown in green over here. So about 53-55% was sickle hemoglobin, and the remaining, shown in red over here, was this hemoglobin that was introduced, the hemoglobin A T87Q. So as you can see from these graphs, not only their hemoglobin went up after treatment, so went from 8 grams to about 11 to 13 grams, but half of it was sickle and half of it was the new hemoglobin that they introduced. So this is what I was telling you earlier. We are not removing the sickle gene, we are just adding a normal gene. And so you still make the sickle hemoglobin, but the half of it is normal hemoglobin. And by doing that, these individuals become like somebody who has sickle trait, and like sickle trait individuals don't have sickle cell symptoms. After treatment, most of these people did not have any symptoms either, and they were cured of their sickle cell disease.
So we do have a question. Someone
Mhm.
stated that they read an article a while back about this bluebird bio trial, and that it was shut down for a little because um, two people showed up with blood cancer.
Yes, I'm going to talk about towards the end. So if you'll hold that thought for a little bit, I'm going to come to that. Um, but before that, I wanted to mention this thing. So this company, Bluebird Bio, has actually filed for FDA approval, and the expected cost of this treatment is going to be around $2.8 million. They've already gotten approval for this therapy to treat patients with thalassemia, and for thalassemia treatment, they are charging $2.8 million. So we expect that probably the cost for sickle cell disease treatment is also going to be around that. And I wanted to mention that because it's not a cheap treatment; it's a very very expensive treatment, and we don't know yet if insurance is going to pay for it or not, or how the payment structure will look like. So there is a lot of unknowns about that. Okay. So I want to show you this diagram over here. It's called a swimmer plot. And what is done in this is each line is an individual patient. So 1, 2, 3, 4, these are all individual patients. To the left hand side in the gray is the 2 year time period before these individuals underwent gene therapy. And on the right hand side in yellow is the time period after gene therapy. So you can see the longer the line means that's how long they have um, been in the study after gene therapy. And each diamond over here is a sickle cell related event. So either a vaso-occlusive pain crisis or acute chest syndrome. And as you can see, most of these individuals before undergoing gene therapy, they underwent gene therapy at this time point, at the gray line in the middle. So on the left hand side, before undergoing gene therapy, all of them had multiple sickle cell related pain crisis. But after undergoing gene therapy, on the right hand side in the yellow, only three people. So this one person over here, and then these two people over here had any sickle cell related events. As you can see, the diamonds almost disappeared in everybody else. So this is a very very effective treatment in most of these individuals, except for these three people. They did not have any sickle cell related events after undergoing gene therapy. So it's a very effective treatment, I should say, which in most of the individuals led to um, complete elimination of sickle cell disease related events. And even in these individuals, if you look at this individual, they had so many events before undergoing gene therapy, and after gene therapy they only had 4 events. So even in those people that had events after undergoing gene therapy, the number was really reduced. So I could not say that this person was completely cured, but that's why I like to use the term transformative therapy, because I think their life was definitely transformed, because previously they were having so many different sickle cell related events, and after treatment, even though they were not cured, they had so few events that I'm sure their life must have been transformed after that. So I like to use the word transformative therapies rather than curative therapy, because not everybody will be cured. There will be some individuals who will gain some benefit, probably not complete cure.
So we do have another question, and it is about this slide. So is it possible that your sickle cell can come back or revert with this process? Because with bone marrow transplant, you can reject it and still have crisis attack, or um, it could be a success, but it doesn't. Of course, it doesn't clear up organ damage or anything, but you still may have pains and stuff. So looking at the chart here, it looks as if at the beginning, especially the first person, that they were fine for almost a year. But then
Mhm.
as time progressed, a few months, it looked as if maybe they were going back, like it was regressing. So is it a possibility that with this procedure, that it's a possibility of you find it out maybe the first year, okay, you're fine, no crisis attack, but 2, 3, 4 years down that it didn't
Yeah.
work.
That's a very important and great question. Thank you for asking that. You should get a chocolate, whoever asked that question. Uh, Dominique, please send them a chocolate if you can. This is a fantastic question that's very important. So, um, gene therapy is a very, very new treatment. This type of gene therapy that we are talking about today, it's only been around for about 10 years. And as I showed you earlier, you know, the oldest patients who have received gene therapy, it's only been about 3 years earlier, 38 months, right? So we don't know about gene therapy, what's going to happen long term. We certainly hope that once you do gene therapy and they are making this much normal hemoglobin, that it'll continue for the rest of their life. But we're not absolutely sure about that. We have a very good reason to believe that that will be the case, but it may not happen in everybody. And in some people, it is possible that their own cells, which are left behind and have not been killed because of busulfan, because of the chemotherapy, they might grow back. And, I don't know what happened exactly to this patient, but your observation is very clear that it seemed like initially they were doing fine and then they started developing events, and then same thing happened here too, like this person was doing fine for this long and then they started having events. So it is possible that maybe their own cells grew back, or maybe the gene therapy, it wasn't as effective. And so with longer follow up, we may see things changing. And and that's remains an unknown question right now. We just don't know that yet. And I think that's an important point that you brought up. We need to be talking more about it, because I think a lot of people these days, they hear the word gene therapy, and they hear and they think about how good it is and how it doesn't cause all the problems that transplantation caused, but they don't understand that gene therapy is so new, that there are a number of things about gene therapy that we don't know yet. And that's very, very important if you're going to make a decision, especially if we are making a decision for a young child. Let's say somebody who is 12, 13, 14 years old, and that child's parents are making that decision for that child. What might happen 10 years from now after gene therapy, we just don't know that yet. And so I think it's a very, very important question, and thank you for bringing it up. I think it's fantastic that you asked that question. It could happen. I don't So as far as we know, nobody has rejected their cells, because in order to reject those cells, you need those cells to be of somebody else's, but those cells may not grow as well. And that is a possibility. So thank you. This is a great question. Any other questions?
No, it was a follow-up question. Did we know if any that's rejected this process? But you answered that.
No, yeah, nobody else has rejected, to our knowledge. Okay. I do want to briefly mention another study that was being conducted out of Cincinnati Children's Hospital by a company named Aruvant. Dr. Poonam Malik was the main investigator for this study. So, like I told you, for the bluebird study, they were using HPA T87Q. That was the name of the globin gene. In this study being done at Cincinnati, they were using a different globin like gene, but they were also packaging that inside a lentiviral vector and introducing it into the cells. They treated 4 patients, and these patients were followed up for about 6 to 36 months. So, again, about 3 years. And in all of these patients, there was clinical improvement. They had less events related to sickle cell disease after treatment. But unfortunately, this trial was now closed. The company that was running the trial didn't want to continue doing it, and they shut it down. So this happens sometimes. Companies make priorities and decisions based on business decisions, financial reasons. Even though these four patients who had been treated, they were doing okay, they were doing better, though they were not cured completely. They were still having vaso-occlusive crisis, but they were having fewer of those. The company decided that it wasn't in their best interest and they shut the trial down. So just one slide about that, because this was something that was being done and you may hear about it, but this study is not going on anymore. Okay, so as I mentioned earlier when we started talking, gene therapy, there are some advantages. So, first of all, you don't have to find a donor and you don't have to worry about graft rejection or graft versus host disease because you are your own donor and you're getting your own cells back. But these bottom complications of transplant are still seen with gene therapy because most of the trials, almost all the trials, every single trial is using busulfan chemotherapy. And so that comes with all these risks. And like I said, there are a number of unknown risks, things that we don't know yet about. And one of those unknown risks was something that you brought up. One of the people asked a question about this study. And so in 2021, I think, 2021, February, they announced that a second patient had developed leukemia after undergoing gene therapy, and they shut the study down for a few weeks. And what happened was, um, well, let me give you the answer first. um, First of all, this was not related to the lentiviral vector. They were worried that lentiviral vector might have caused leukemia in these patients. That was not the case. It happened because of different reasons, which I'll talk about in a little bit. But let me tell you why they were concerned. So, what happens is when a lentiviral vector, it goes inside a gene, this lentiviral vector inserts the DNA that it is carrying into the the cell. So into the DNA. So again, I'll show you an analogy. So as I told you earlier, this is the spelling mistake, and this is what lentiviral vectors do. They just introduce the normal spelling somewhere. What if they introduce the spelling inside a word, inside a normal word? So instead of putting it like this at the end of the sentence, what if they put the normal spelling in the middle of a normal word? That would cause some problems, right? So it would mess up things even further. So that is what the concern was. So let's say if these are different genes, this is one gene and this is another gene, what lentiviral vectors do is they are supposed to get in between these genes and insert themselves somewhere. This is normal. If a lentiviral vector goes in middle of these two genes, that's great. That's what it's supposed to do. But let's say there is a good gene and this lentiviral vector goes and gets inserted inside this good gene. It will break this good gene. So whatever this good gene does, it won't be able to do that anymore, and that'll make things worse. So this is bad. We don't want this to happen. But even worse than this, there are certain genes in our body which are cancer suppressor genes. They prevent cancer from happening, and if they get activated, if they get turned on, they can cause cancer. There is a worry that this lentiviral vector can get inserted right before a cancer gene and it can activate this cancer gene. And if that were to happen, the cells could develop leukemia. And that is what the concern was, that in these patients, maybe that might have happened. And so when this happened, when the company found out that two patients had developed leukemia, they actually did a lot of investigations. A lot of scientists worked together to figure out what happened, and they published two different reports in these two journals. And they figured out that it wasn't the lentiviral vector. In actually one of the patients, the leukemia cells did not even have the lentiviral vector in them. And in the other patient, while the leukemia cells had lentiviral vector in them, but the lentiviral vector was not anywhere close to any cancer gene. So we figured out that it wasn't the vector which caused leukemia. There are other reasons why this might have happened. We don't know that for sure. One of the things is that you know when people get exposed to chemotherapy, as I told you earlier, exposure to chemotherapy might cause some cells to develop leukemia. It is very, very rare, but it can happen. So it's possible that that might have happened in at least one of these patients. The other idea is that individuals with sickle cell disease, because their bone marrow is turning over so much, some individuals with sickle cell disease can develop leukemia because they just develop a mutation in one of the genes that can cause cancer. And so there is another idea that maybe that happened. We just don't know that for sure, but we were able to figure out that the virus did not cause leukemia in these patients, because that would have been very bad. But we do still need to have long term follow up, because we don't know what might happen to patients in 10 years or 20 years, because none of these patients have lived 10 or 20 years after undergoing gene therapy. So long term follow up is ongoing. The FDA, the agency, federal agency which approves all these um, um, new drugs, they mandate that these patients undergoing gene therapy be followed for a period of at least 15 years, so that long term follow up can be collected. So that is still ongoing. And hopefully, nobody else will develop leukemia in these treatments after these treatments, but we'll find out. We will know, hopefully, in due course of time.
We do have a question. Someone asked, they're just curious. They want to know, curious about how many people um, have had gone through the gene therapy process for sickle cell disease.
So I don't know the exact number, but I think, safely tell you that it's probably less than 100 patients, less than 100 people on all the different trials across the world. And in this particular trial, I think there were a total of maybe 45 patients, out of which the 35 patients were treated on Group C.
Okay. We do have another question.
Mhm.
How is long term follow up conducted from pediatric care to adult care for the participants that age out of pediatric care? Is
Yeah,
an adult care provider educated and expected to report data?
that's a really good question. I'll tell you that. So first of all, most of the patients that were treated on these trials were treated on by adult providers. So they were all over 18 already when they were treated. The number of children who were treated are actually very few. So since most of the people were already treated by adult doctors, they just continued to be followed by the adult doctors. But you bring up a very good point. What if somebody is treated as a child and then they turn 18? What about them? To be honest with you, I don't think most people have figured that out yet. We are working on it. Even at my institution, we are still trying to figure out what are we going to do. So one of the ideas is that, for anything related to long term follow up, I would actually recommend that those people should go back to the same center where they underwent gene therapy, because at that center they have the expertise, they know what happened, they know what to do, what kind of gene therapy they had and all that. So they should go back to the same center. But if that center does not have the capability to follow adult patients, then those patients need to be referred to a provider who knows what gene therapy is, how it works, what the complications are, and so forth and so on. So I think most places are trying to figure out what they are going to do, but I don't think everybody knows the answer quite yet. You guys are awesome. You guys are asking so many good questions. This is fantastic.
They are.
Okay, so I talked about the gene addition type of gene therapy today. Next week, we will talk about different other types of gene editing and gene suppression. Basically, we'll talk about CRISPR-Cas9 gene editing. We'll talk about base editing. We'll talk about some gene suppression, and then precise correction of the gene mutation. Um, Before I go forward, I should mention one thing which I mentioned last week as well. Whether we do transplant or we do gene therapy, it only fixes the blood cells. It does not fix the rest of the cells in your body. And so, what that means is, if somebody has undergone gene therapy or transplantation, when they have children, they can still pass on the sickle gene to their children. It does not change the genes in your gonads. It does not change the genes in your ovary, in your eggs, in your testes, in your sperm. It does not change that. So even after being cured of sickle cell disease by transplant or gene therapy, you could still pass on the gene to your children. So that's one thing. And then the other thing is, whatever damage sickle cell disease has done to the body um, before transplant or before gene therapy, that may not get better. So if somebody has already had a stroke, the stroke might not get better after gene therapy. And so there are certain things that don't improve even after gene therapy or transplant. And I think people need to know that as well. So, one thing that you could do if you're thinking about gene therapy or transplant, keep your body healthy, stay on your medications, take those regularly, try to prevent any complications as possible, as much as possible, because the healthier you are going to transplant and going through gene therapy, the better you will feel, the faster you will recover. Um, and you will have healthy organs afterwards. So with that, I will stop. Thank you so much for all your attention. I'll stay back for a little bit over here. If you have any questions, I'm happy to answer those. If I'm not able to get to those questions, this is my email address, akshay.sharma@stjude.org. You can email me. And I also tweet about sickle cell disease. So if you hang out on Twitter, follow me at Akshay Sharma MD, and we can have a conversation over there as well. And lastly, once again, I'm happy to take any general questions. But if you have any specific questions about yourself, about your health, please refer to your hematologist or your primary care provider. Thank you so much for your attention.
Thank you so much, Dr. Akshay. I actually do have a question, um, and it's going back to the lentivirus viral vector and how they answered it and how it was said that it doesn't change, it doesn't make it grammatically correct, and then you showed how if when you put it in, it could make it look like this instead of that. Have they found a way to make the lentivirus go where that addition needs to be made or that correction needs to be made?
No, so at least to my knowledge, I don't think that's been done. I know people have tried that a lot. They want the lentiviral vector to go somewhere, but as far as I am aware, I don't think that's been successful yet, and that is the reason why people started developing other treatments like CRISPR-Cas9, which we will talk about in the next week's class, because we've known about lentiviral vectors for a long time, about 20 years or so, and this was the very first clinical trial to start, which is great. We needed a better treatment, a new treatment for sickle cell disease. High time now. So it's great that we have that treatment, but we shouldn't just stop because we have one treatment. We should make it better. And so one of the ways in which they tried to make it better was by using CRISPR-Cas9, and I'll show you how that is different in the next week's class. So please join us again next week.
All right. So I'm checking. It looks like we do not have any question, but we do have a lot of people that say good information. They say thank you so much for your presentation. It was very informative, very understanding. We have people saying you rock, Dr. Akshay. Yes, you do very
Thank
much.
you.
Uh, so thank you all. Thank you to the participants. Thank you to everyone who asked questions. And a very, very special thank you to Dr. Akshay. This was an amazing presentation. As always, thank you so much. And we will see everyone next week, next Thursday at 7 p.m. Eastern for Comparative Technologies 3. So thank you all so very much for joining us. Thank you once again. If your question did not get answered or you think about your question later, please feel free to email it at, I'm putting it inside of the chat as well, WARRIORUNIV at sicklecellconsortium.org. And we will make sure we answer those questions first thing at the start of the session next week. Thank you all so much and have a good night.